Okay? So this one, ay naririnig naman ako, Troy. Okay naman? Tama ba?
Yes, Doc. Perfectly.
Okay. Sige. So for cellular responses to stress, so ito yung table that summarizes everything that you have to know dun sa cellular responses to stress. No? Okay? So kapag tinanong kayo sa boards, usually hindi yan tinatanong ng diretso. No? Usually they will give you a case. For example, a 55-year-old male may retrosternal chest heaviness, no, cardiac troponins elevated. What's the pattern of necrosis that you see? No? So actually, sa mga ganitong bagay, kailangan alam nyo kung ano yung nature of the stressor, no? Or kung ano yung nature of insult. And then alam mo kung ano yung tissue type para malaman mo kung anong klase yung cellular response to stress. So yun lang ang gusto kong i-point out doon. Alam nyo na yan, no? Alam nyo na yung ano niyan, alam nyo na yung technicalities niyan. Pero paano mo siya i-apply sa case? Okay? So you have to know the insult first, and then you have to know the type of tissue involved, and then you can determine what kind of response. So in my example, it's myocardial infarction, so you have to diagnose it first, and then you know that this is an ischemic lesion in a solid organ, which is the heart, then it's coagulative. So ganun mo siya i-apply, okay? And always remember the difference between your apoptosis and necrosis, yung table na yon sa handout nyo, because lagi siyang lumalabas. Okay? Now, for types of inflammation is something that I will linger a little bit longer kasi maraming non-neoplastic disorders in your systemic pathology are inflammatory disorders. Your infections, your autoimmune diseases, lahat yan basically nagbo-boil down under inflammation and repair. No? So for the types of inflammation, we have two types, no? Your acute and your chronic. Okay? So pag acute, alam nyo na neutrophils ang nakikita nyo. Pag chronic, usually your mononuclears, and you know that your stand processes usually have more severe tissue injury. Therefore, clinically, your acute inflammatory disorders will present with infection or typical clinical manifestations of your leukocytosis, pain, no, mga ganyan. But for your chronic inflammatory disorders, which most autoimmune diseases fall, no, usually the chronic inflammatory disorders will present with impaired organ function because of fibrosis, no? Because you decrease the proportion of the living tissue, no? Kasi nga mas marami kang fibrous scar. So yun ang tatandaan nyo. Even the clinical presentation and even the complications of your acute and chronic inflammatory disorders will center on those basic facts, okay? Now, take a screenshot of this kasi nagtatanong ng inflammatory mediators and functions, and I group them according to common function. So please take a screenshot of this. Okay? Okay na ba? O sige, 5 seconds. 1, 2, 3, 4, 5. Okay? Okay na? So yan, magagamit nyo yan for your summary. Magagamit nyo yan for your summary kapag nagmamastery na kayo. Now, for the types of repair, there are two. No? You have your regeneration and your connective tissue deposition, or I'd like to call it fibrosis na lang to be basic. So basically, regeneration happens in tissues that are capable of regeneration, no? And your connective tissue deposition happens in those that cannot, no? Those that cannot regenerate. And also in the setting of your chronic severe infections, because these infections, they have severe tissue injury and they destroy the stem cells, no? So kahit replicating pa yan, kung sobrang lala na ng injury, wala nang stem cells, so fibrosis na lang tayo ganon, okay? And also, one interesting fact is that your fibrosis happens when you have fibrin. Okay? So, if it's a fibrin-rich environment, that will heal by fibrosis. So, ano-ano ba yung mga fibrin-rich? Hemorrhage. Okay? And that's the reason why yung mga hemorrhage na nakikita nyo dyan sa systemic pathology nyo, mga nag-heal sila by fibrosis. It's because there's fibrin in your blood. No? And then, next is yung, yung chronic inflammation. Okay? And another pala na may fibrin is yung mga abscesses. Lalo na kapag naging hemorrhagic abscesses sila, no? So they're fibrin-rich and they also will heal by fibrosis. Now, for your hemodynamic disorders, if you have increase in extracellular fluid in your tissues, no, that's what you call your edema. But if it happens in your body cavities, your peritoneum, pericardium, No, ano pa? Pleural cavities. Those are what you call your effusions. And remember that we have two types of effusions, no, your exudate and your transudate. If you have increase in blood volume in your tissues because of an active process and arteriolar dilation, such as in acutely inflamed tissues, that is what you call your hyperemia. Okay? And if you have increase in blood volume in your tissues due to decreased venous outflow, that is your congestion. Hindi kasi makalabas yung deoxygenated blood. Dapat kasi aalis yan sa tissue, no? Pero pag hindi makalabas, then the tissue will become congested. If you have abnormal hemostasis in your blood vessels, that is your thrombosis. And if you have different substances, no, pwedeng part of thrombus or other exogenous substances within your vasculature, that can cause either mechanical obstruction or activation of your coagulation cascades or inflammatory cascades, no? Those are your embolus. Those are your emboli. Okay? If you have decrease in blood in tissues, that is your infarction. Remember your myocardial infarction. Walang dumadaloy na dugo dun sa isang part ng heart, no? But if that occurs in the body, if you have decreased effective circulating volume, that is what you call your shock. Now, concentrating on shock, we have 5 types, no? Your cardiogenic, pag sinabing cardiogenic, think lahat ng conditions na pwedeng mag-cause ng heart failure or failure of heart to function properly. For example, if you have tension pneumothorax, it can compress the mediastinal structures and therefore render the heart unable to fill blood. So may diastolic failure ka. So that's cardiogenic shock also, no? It's a kind that you call your obstructive shock. So for your hypovolemia, self-explanatory if you have fluid losses, no? For systemic inflammation, you have your septic shock, which is caused by widespread endothelial activation because of the infection, no? Widespread endothelial injury because of the infection. And of course, the cytokines that are produced in response to inflammation, no? Now, for your neurogenic shock, these are caused by the loss of sympathetic vascular tone. And for your anaphylactic, you know it too well. No, it's an IG-mediated hypersensitivity. Now, for your genetic disorders, these are the types. Now, we have your Mendelian, we have your chromosomal, your trinucleotide repeats, and your genomic imprinting disorders. So, these genetic diseases, common na itanong yung kanilang pattern of inheritance. But sometimes they're going to make it more difficult for you in such that they're going to make a case about it, no? So this table will help you, no? This table will help you sort their features, no, their clinical features. So please take a screenshot of this, no? 5, 4, 3, 2, 1. So remember in your in your cognitive domains, no, in your cognitive domain, no, or cognitive symptoms, yung nagko-cause ng mental retardation, marami except for your Klinefelter. Remember that Klinefelter does not cause mental retardation or significant intellectual disability. Low IQ lang, so medyo nahirapan lang sila, no? Pero hindi sila mentally retarded. Okay? And then this one, I would also, this is a continuation of the table previously presented. So please take a screenshot of this. Yan. So as you can see, ang daming features, no, ng genetic disorders. So at least kung magtanong sila na which one has endocrine abnormalities, at least alam mo kung anong pamimilian mo. Which one is associated with aggression, you can see that agad-agad in this table rather than look isa-isa dun sa diseases in your main handout kung di nyo pa na-synthesize yung information from there. Okay? Now, let's go to your diseases of the immune system. So, dumiretso na tayo sa Gel and Coombs classification. This is also a high-yield concept. Lagi itong tinatanong every season. So, let's review. You have your 1, 2, 3, and 4. Your 1 is your allergies. It's IgE-mediated. Your type 2 is antibody-mediated. And you know that your antibodies, if you recall your inflammation and repair, can activate your complement system, diba? And it can cause damage through 3 sub-mechanisms, no? Your opsonization and phagocytosis, your inflammation, and these 2 are because of your complement activation, or it can alter the function of your target cells without significant organ damage. Now, your type 3, these are your immune complex mediated disorders, and you know that they're like garbage. They get deposited everywhere, especially in your blood vessels, and you know that these immune complexes can activate your complement system and can cause inflammation and then organ damage. Okay, and then yung type 4 depende kung CD4 or CD8. Usually CD4 operates by cytokine production and inflammation, while your CD8 are capable of directly killing your target cells. So just remember your systemic autoimmune diseases, your SLE, your Sjogren, your systemic, your mixed connective tissue disease. So just remember their main clinical presentation, no, and your notable autoantibodies. Okay? Para ma-diagnose nyo sila, and then you just pick the relevant information. You just pick out the relevant information from your memory. So for your SLE, you know your SOAP brain MD mnemonic. So it involves multiple systems, and these are the notable autoantibodies. For your Sjogren syndrome, the main clinical presentation is the lack of secretions because it attacks your lacrimal and your salivary glands. While for your systemic sclerosis, it's fibrosis involving a lot of systems. Okay? Now, we also have, kung meron tayong mga autoimmune diseases, meron din tayong immunodeficiencies. And yung immunodeficiency will, of course, present with infections. No? So, depende kung anong arm of immune system yung involved, yun yung magdidikta ng abnormality. So pag innate, usually granulocytic function yung involved, so impaired ang neutrophilic response mo, or you can have complement deficiencies. For adaptive, because it involves your T and your B lymphocytes, no, it affects the maturation pathways ng lymphocytes na yon. So if the block occurs early on, then you will have deficiency of both B and T cells. You will have SCID. For B cells, you will have Bruton. No, and you will be susceptible to extracellular pathogens because you don't have immunoglobulins. Now, for T cells naman, your thymus does not develop and dun galing yung T cells. So you are susceptible to fungal, viral infections, and those hardy organisms, no? Like your TB, mga ganon. No? And if Ig class switching naman, your B cells become your plasma cells. If you have problems with Ig class switching, you can have isolated immunoglobulin deficiencies. Okay? Now, AIDS is the most serious secondary immunodeficiency. So you know that aside from immune system, it also affects the CNS. And bakit ganon? It's because of microglial infection. So your microglial cells are your CNS macrophages. And you will later realize that your HIV does not only infect your T cells, it will also infect your macrophages and your megakaryocytes because they also have the CD4 receptors in them. Okay? So what's the main abnormality in the immune system of your patients with HIV? Alam na alam nyo to, bumabagsak ang kanilang CD4. No? Now, the phase of HIV infection where partial control of viral load occurs due to host's immune response, this is your acute phase. Remember your acute phase of HIV infection, of course, there's viremia, no? There's viremia, but of course, when there's something that's foreign in our body and we still have an intact immune system, then basically, magre-respond pa rin tayo, and that will lead to a partial control in your viral load. So, pag taas niya, babagsak siya ng konti. No? And then mag-enter siya dun sa other phases na, no? Yung chronic phase and then yung AIDS. Okay? And then ito yung sinabi ko, the reason why MEGs and your monocytes can be infected with HIV is because the presence of compatible receptors. You have your CD4 receptors. And what are the main groups of diseases that afflict your AIDS patients? Remember that your AIDS patients suffer from double burden of disease. Bukod sa infections, they suffer from tumors because of oncogenic viruses. Okay? So for neoplasia, let's make things a little bit practical. If you have a 57-year-old male who's a non-smoker presenting with a lung mass that's 4 centimeters on imaging. So what's the most important clinical information to elicit? It's history of other cancers. Remember that your lung, if you recall your chapter 14, lung is the most common site of metastatic neoplasms. And lung mets is the most common malignant lung tumor. No? So, whenever you have a lung tumor, you always have to rule out mets first. Now, if this is a primary tumor, you diagnose. And this is where your nomenclature comes in. So, this one is malignant. The cells are ugly. The architecture is not organized. But you see these tubular structures. And these are your glands. And pag sinabing glands, adeno. Okay? And it's a malignant epithelial neoplasm. So, it's an adenocarcinoma of the lung. Okay? So remember your nomenclature, no? Parang exorcism 'yan. Kailangan alam mo yung name ng tumor for you to have power over it. Okay? So you have to master your nomenclature. Now, what are additional tests that we have to uh request for to ascertain the lineage of this tumor? You do your IHC kasi nga syempre adenocarcinoma yan. Malay mo ba kung adenocarcinoma yan galing sa ibang lugar, 'di ba? So, yon. So if this is a primary adenocarcinoma, well, it's nice to know lang naman, no? The immunostain, the positive stains are your thyroid transcription factor 1 and your napsin A. Well, that's already advanced, but I just want you to see an application of your neoplasia principles in real life. Okay? So what's the mutation expected in this patient group and cancer hallmark observed? Your EGFR, and your EGFR is an oncogene, no? It's an oncogene. So the cancer hallmark is your self-sufficiency in your growth signals. In your lung cancer patients, when you become clinicians and you become oncologists, no, your EGFR is prognostically important, no, and your EGFR is a targetable mutation. Meaning, kapag may EGFR mutation ang lung cancer, pwede mong gamutin by anti-EGFR therapy. Okay? Kaya siya importante. So, hindi lang sila basta sauluhin. Siguro kung hindi nyo sila magagamit sa boards, magagamit nyo sila after. No? So, i-appreciate nyo pa rin. Okay? Now, this one is an elderly male with a retroperitoneal mass 6 months prior. So, as you can see in the picture, medyo may nakikita kang taba, pero between those taba, merong atypical cells. Okay? So, mukhang adipocytic neoplasm ito. So, is it benign or malignant if you look at the clinical history? It's 15 centimeters in 6 months. Mabilis yon, mabilis yung growth rate. So, benign or malignant, mukhang malignant yon. Ang laki pa, no? And it's deep-seated. So, recall your general principles of your soft tissue tumors. Now, is it epithelial or mesenchymal? I see fat, no? If I see fat, fat is a soft tissue. Therefore, it's mesenchymal, no? Now, diagnose, it's well-differentiated liposarcoma. So you see your mature fat cells, but you see your atypical stromal cells, no, in between. And this is because of your MDM2 amplification. And if you recall in your lectures and your handouts, your MDM2 is an inhibitor of your P53. And your P53 guards your genome, no? So if that is inhibited, then pwede ka magkaroon ng cancer. Okay? So this one naman is an elderly male with a thigh mass, 20 cm, 3 months. Ang bilis-bilis. So siguro benign or malignant, it's malignant, no? And also, if you look at the picture, baka naman ang pangit, no? Pag pangit-pangit, malignant na yan. Okay? So additional test to a certain lineage, well, sa sobrang pangit niya, hindi ko alam kung saan siya galing. So, it's undifferentiated. We need to do your IHCs. And you have to diagnose based on the following IHC results. So, as you can see, you have here leukocyte common antigen positive result, no? Which indicates hematolymphoid differentiation. Your cytokeratin is negative. It means it's not epithelial, no? Your CD20, which is a B cell marker, is positive. So this is a high-grade B cell lymphoma, no? So it's lymphoid, no? It's a lymphoid. It's a malignant lymphoid neoplasm. It presents as a mass. Okay? So for severe yung infectious diseases, I will skip that. Basically, ang meron kasi sa infectious diseases, no, doon sa trends, ang nangyayari kasi, they tend to be more clinical, no? They tend to be more clinical. And therefore, kaya ko ni-revise yung handout nyo such that I gave, no, particular importance in the clinical features. So yun usually yung tinatanong nila for infectious diseases, but of course, it doesn't hurt for you to remember their morphology. So yun lang yung may i-share ko for infectious diseases. Now, moving on, marasmus and kwashiorkor is quite a highly recurring topic, no? Parang across seasons, lagi siyang lumilitaw. So we have to know the difference. So kung ang protein malnutrition ay greater, ano siya? Marasmus or kwashiorkor? It's kwashiorkor, no? If you have severe wasting, sobrang payat mo, anong meron? It's your marasmus. Kasi yung marasmus, somatic protein compartment yung na-affect niya. Now, if you affect your if the visceral protein compartment is affected, that is your kwashiorkor. So mawawalan ka ng albumin, tapos dahil doon magkakaroon ka ng edema, no? If you have caloric deprivation, ano yon? It's more of your marasmus, no? And if you have a hypoalbuminemia and edema, as I previously mentioned, that is your kwashiorkor. Okay? Now moving on.
Kevin,
Hello?
magkano
Yes.
may kailangan ko mabilis na announcement.
Mm-hmm.
May mga nagtatanong dito sa akin, guys, ang summary lecture, you're not supposed to actually write notes.
Yes, totoo.
Or whatever. Ang pag-summary lecture, the one that we recommend that you do is really just to listen.
Listen. Yes.
Because everything in your summary lecture is actually already in your main handout.
Yes.
So,
Hindi na kailangan.
yung mga nagno-notes kasi, Kevin.
Ay, no.
Nor.
Okay.
Medyo hardcore, guys.
Oo.
Honestly, habang nakikinig kayo ng summary lecture, have a beer, just grab coffee, grab some snacks para lang kayo nanonood ng TV. Popcorn.
Oo, B.
Hindi kayo
ASMR
dapat
lang
toxic pag summary lecture na ganito. Okay?
Mm-mm.
Dr. Kevin is allowing you to take screen caps nung certain slides like this. But personally, guys, kahit hindi na nasa handout niya lahat yan. So, we want you to focus on the main handout. You treat the summary lectures basically like dessert na kinain ninyo.
Oo.
Dapat natutok sa summary lecture.
Oo.
Grab a beer, grab coffee, whatever you want. Just listen and enjoy the lecture.
Oo. Wag na kayong magsulat kasi ang toxic na nga ng patho as it is. Summary lecture lang to. So, wag na kayong magsulat. Okay? Sasabihin ko lang yung mga importante, no? Okay. So, let's go to the representative pediatric diseases. So, pag hyaline membrane disease, alam nyo naman, this is your neonatal RDS. So, ang nangyayari, di ba, you have surfactant deficiency and you have decreased lung maturity here, no? So, dahil doon, basically, you will have poor ventilation and that causes also poor perfusion, no, eventually. And pinaliwanag ko yan in detail in the handout. Basically, if you have poor perfusion, no, anything that has a poor perfusion will necrose and will die, no? At dahil doon, yung necrotic debris na yon will organize into hyaline membranes and that further exacerbates your hypoxemia, no? Kaya ka nagkakaroon ng respiratory distress. Now, for your necrotizing enterocolitis, no, you have you damage your bowels, which causes loss of mucosal integrity. And therefore, if you have enteral nutrition, so kung pinakain nyo agad sila, no, pinadede nyo agad sila, then may na-introduce agad na bacteria sa gut nila which can translocate to the bloodstream causing neonatal sepsis. Yun yung necrotizing enterocolitis. Now, for your cystic fibrosis, this is highly recurring, no? This is highly recurring. And alam nyo naman yung CFDR defect siya. It's an ion channel that handles your chloride and related ions like your bicarbonate, no? And the sine qua non of this is your salty sweat, no, because your chloride does not go in, no, and stays in the lumen of your sweat glands. Okay, so yung sodium at yung chloride nagsasama, nagiging salt, kaya salty ang sweat. Now in other mucosal linings, no, ang nangyayari is nagkakaroon ka ng dehydration, no? Nagkakaroon ka ng dehydration and the mucus becomes plugs, no? Kaya ang cystic fibrosis ay mucus plugs. Yun ang morphologic findings niya. And of course, those can cause organ dysfunction, no, in the lung, it can cause persistent infections, no? So mga ganon. Okay? Now, for your pediatric tumors, these are your blastomas, no? So, yung neuroblastoma, tandaan nyo sa kanya, pediatric patient, you have a midline abdominal mass, no? Or an abdominal mass that crosses the midline. Remember that this arises in the adrenal medulla. So, basically, pag lumaki yun, magkocross talaga siya ng midline, no? And small round blue cells ang general morphology ng pediatric, ng small round blue cell tumors of your childhood, no? And homocyte pseudorosets can be seen in your neuroblastoma. While for Wilms tumor, aside from the mass that can also cross across the midline, no, meron siyang hematuria. Kasi nga sa kidney ito, no? So meron siyang renal manifestation. So yun yung difference niya from your neuroblastoma. And aside from the small round blue cell tumors, no? Yung Wills tumor, the morphology is your classic triphasic tumor, your blastema, your epithelia, and your stromal or mesenchymal, no? Kaya ako siya ginawang stromal para best yung kanyang ano yung tawag doon? Yung kanyang mnemonic. Okay? So, okay pa ba? Okay. So, let's start with the systemic pathology. So, yung vascular pathology in summary is this, no? So, basically, if you have luminal narrowing, no? If you have luminal narrowing, that increases the resistance to blood flow. And that will cause what? Hypertension, no? That will cause hypertension. So, depending on the etiology of your hypertension, you can have your hyaline or your hyperplastic arteriolosclerosis. Your hyperplastic arteriolosclerosis is in your malignant hypertension, while your hyaline arteriolosclerosis is in your usually caused by your diabetes, your hypertension. At any rate, luminal narrowing ang common feature, and that causes hypertension. Now, your atherosclerosis is a classic example of the stereotypical vascular response to injury, no? And because of the injury, the two important causes ay turbulent blood flow like your hypertension, no, and your hypercholesterolemia. Okay? So those are the important causes of your atherosclerosis. Well, aside from your diabetes, of course, no? But in terms of lesions, ang tatandaan nyo, it starts with the fatty streak. Hindi yan isang malaking plug agad, no? It starts with the fatty streak and then it builds up until it becomes a full-blown atheromatous plaque. Now, remember that the plaque can undergo acute plaque change, and that can cause your abrupt cessation of your blood flow, and that explains why you have acute coronary syndromes, no? Yun yung kanyang significance. Now, if you have weakening of the wall, no, from various causes, then you can have aneurysms, which is a dilation of your vessel, or a dissection wherein you have an intimal tear and the blood dissects through the vascular wall. Okay? Important lesion is your cystic medial degeneration because the insults will destroy your vascular wall and you lose your elastic fibers. Okay? Now, kung meron ka namang vasculitis, of course, it's itis, it's an inflammatory disorder, no? It will cause inflammation of your blood vessels, and you know the typical pattern of necrosis that you see in your immune vasculitis is your fibrinoid necrosis, no? Remember that in your vasculitis there are different forms, but basically clinically ang presentation niya is if you destroy your blood vessels, if you injure your blood vessels, they can either rupture causing hemorrhage or they can become thrombosed and obstructed and can cause ischemia. Okay? So yun ang clinical presentation ng vasculitis. And of course, if you have oncogenic mutations in your endothelial cells or the supporting structures, then you can have your vascular tumors. Remember, we have different vascular tumors ranging from benign to malignant ones. Now, for your heart failure naman, we have your left-sided and your right-sided heart failure. If the left side fails, it will not pump blood out of the heart, and therefore, saan maiipon yung blood? Sa lungs. But in your right-sided heart failure, kung hindi magpapump yung blood papunta sa may pulmonary circulation, saan siya maiipon? Sa systemic venous system. And that explains yung clinical manifestations of your left-sided and your right-sided heart failure. Okay? Now, for congenital heart diseases, we have three groups, no? Your left-to-right shunts, right-to-left shunts, and the obstructive lesions. So for left-to-right shunt, these are your acyanotic, no? These are your acyanotic congenital heart diseases. Now, because there is increased blood flow to the right side of the heart, there is increased blood flow to the lungs. And that is bad. Bakit? Because if you continually overload your lungs, you will have what? You will have pulmonary vascular remodeling, and that eventually will cause pulmonary hypertension. Pag tumaas ang pressure dun sa pulmonary circulation at sa right side of the heart, the shunt will reverse from right to left, and the patient will present with cyanosis, and that is what you call your Eisenmengerization. So we have your ASD, VSD, and PDA under that. Now, your right to left shunts naman, remember that the blood should pass the right side of the heart and then the lungs before it gets to the left side of the heart. Kasi kailangan mo siyang i-oxygenate, no? But if nagpas ka diretso from your right side to your left side and you bypass your lungs, basically, the oxygenated blood yung pupunta sa left side and therefore your patients will clinically present with cyanosis, no? So an example of that is your tetralogy of Fallot and your transposition of the great arteries. And then we have obstructive lesions, which can provide increased workload, no, dun sa upstream chambers, and that can cause your hypertrophy. So for example, your coarctation of the aorta can cause left ventricular hypertrophy, especially the postductal one, diba? Parang ganon. Because your constriction will provide additional resistance to your blood flow. Okay? Now, for ischemic heart disease, it's a very important disease group na lagi nyo ma-encounter once you practice. Hopefully, starting October 2023, no? Okay, so we have here your chronic stable angina pectoris. It's a demand problem. So, pag sinabing demand problem, usually the chest pain occurs during exertion, no? But for your acute coronary syndromes, it's more of a supply problem, no? But for your unstable angina and your myocardial infarction, the difference is in your myocardial infarction, there's already myocardial cell death, no? And that clinically manifests as what? Increase in your cardiac biomarkers because tumatagas sila from the cardiac muscle to the blood. Okay? So yun. Now, in terms of morphology, remember that it's coagulation necrosis, di ba? Pagka ischemic lesion ng solid organ. So, it's coagulative necrosis. You know that your necrosis is always accompanied by inflammation. So, it starts, of course, with your neutrophils and then mapapalitan siya ng chronic inflammation, your macrophages, no? And basically, mag-heal siya by fibrosis. Okay? Now, rheumatic fever and rheumatic heart disease. No, this is also a common thing na tinatanong. Okay? So remember lang na ang acute rheumatic fever at ang rheumatic heart disease ay magkaiba. Okay? Kasi ang acute rheumatic fever, ito yung autoimmune. No? Ito yung autoimmune disease. Okay? Ang nangyari dito ay molecular mimicry because there's similarity between your streptococcal antigens and your, cardiac self-antigen. So the body attacks your heart. Okay? And doon mo nakikita yung ash of bodies, your NHCO cells, and the clinical presentation is usually acute MR or mitral regurgitation. Now, you know that this is an autoimmune disease. Therefore, it will heal by fibrosis. And that is where rheumatic heart disease comes in, no? And because it's fibrotic, then you will have mitral stenosis naman. Okay? Mitral stenosis naman. And of course, since puro fibrosis ang nasa RHD, you don't see your ash of bodies. It's puro fibrosis. Now, what's the bad thing about having a rheumatic heart disease? You are predisposed to develop infective endocarditis, particularly the subacute, because you have a damaged heart valve. Okay? Now, for your cardiomyopathies, we have three basic patterns, no? You have your dilated, hypertrophic, and your restrictive. Just remember that your dilated, because it's super dilated, it cannot pump out blood. And therefore, that's your systolic dysfunction, which sa laboratory niya or sa 2D echo niya, you have your decreased ejection fraction, no? Now for your hypertrophic and your restrictive, they're more of a filling problem. For your hypertrophic, of course, you have hypertrophy of the walls, no? And because of that, you compromise its contractility, no? And its flexibility. Okay? You compromise its flexibility. So, yung compliance nung iyong heart chamber because of your hypertrophy ay bawas. Kaya hindi ka makapag-fill ng blood. Kaya siya diastolic dysfunction. Now, for restrictive, matigas yung puso mo, pusong bato ka, so di ka maka-expand. Kaya hindi ka rin maka-fill. Okay? Now, diagnose. This one is a common case. This one is a common case. Lagi ang lumilitaw. So, ano yan? 35-year-old male, a blood smear. So, anong nakikita nyo sa screen? You have our rods, no, in a cell. So, yan. You have our rods. And then, this is a myeloid leukemia, particularly your acute promyelocytic leukemia. So what's the characteristic translocation? It's your T1517. And that T1517 causes its susceptibility, no, to vitamin A, no, to all trans-retinoic acid. So remember the crucial thing about your lead, so dapat lagi tayong prepared. Now, this one naman is an elderly male, no, an elderly male with a lot of lymphocytes in the peripheral blood smear. So, ano yung pointed structure? It's your smudge cell. And ano yung lineage? It's your lymphoid. So, these are your B cells, no? These are your tumor B cells. So, what's the diagnosis? Naabot niya yung 5,000 per ml na cutoff for your lymphocytes. So that is your chronic lymphocytic leukemia. So bakit ka nagkakaroon ng thrombocytopenia in this patient? Remember that this patient presents with gum bleeding. It's because of autoimmune phenomenon, which is notable in your B-cell tumors. So whenever you have your autoimmune hemolytic anemia and your autoimmune immune thrombocytopenic purpura, you check for your SLE, your CLL, no? Okay? And when it transforms into DLBCL, you call that your Richter syndrome. Now, this one is also classic. So this one is a 35-year-old male with a mediastinal mass. So what's the cell in question? It's your Reed-Sternberg cells. And yeah, the diagnosis is your Hodgkin lymphoma when you see that. So wag na yung nodular sclerosis kasi masyado na yung toxic. So, of course, this is a classic Hodgkin lymphoma. You see your classic immunophenotype, your CD30 and CD15. Is it associated with Epstein-Barr? No, some types are associated, some types are not, but this particular type is not. Okay? So, false. Now, true or false, extranodal involvement is common in this type of lymphoma? No, false. Because your Hodgkin lymphoma is primarily a nodal disease. So usually kung saan may lymph nodes, doon siya lilitaw. No? Pag meron kang lymphoma in an extranodal site, non-Hodgkin yun, malamang-lamang. Okay? Now let's go to hemolytic anemias. So alin dyan ang may complement-mediated lysis? No? That's your paroxysmal nocturnal hemoglobinuria. Okay? You don't have your protection, no, against your complement-mediated lysis, kaya inaatake siya ng complement. Now, alin dyan yung anemia because of your red cell trauma? That is your microangiopathic hemolytic anemia. No? If you have your thrombosis, if you have a lot of thrombosis, then syempre may encounter yun ng red blood cell, matotrauma siya, kaya siya masisira. Okay? Alin dyan ang may beta-globin gene amino acid substitution, no? Your sickle cell anemia. So remember your characteristic mutation, no, in your sickle cell anemia. So for your alin dyan ang may cytoskeletal mutation, kaya nagiging less deformable at nalalay sa spleen, that is your hereditary spherocytosis. Now, if you have deficiency in globin chains, no? Ano yon? Those are your thalassemia. And remember na kung ano yung pangalan, yun ang wala. So pag alpha thalassemia, anong wala? Alpha chains. Pag beta thalassemia, anong wala? Beta chains. Okay? So if you don't have NADPH to generate your reduced glutathione, no? Ano yon? That's your G6PD deficiency. Remember your G6PD reaction, it generates your NADPH, and that is important in generating your reduced glutathione to protect your red cells against oxidative stress. Okay? Now, antibodies coating red blood cells, of course, that's your autoimmune hemolytic anemia or your immunohemolytic anemia. Now, let's go to your hypoproliferative anemias. If you have depression in all three lines, that is your aplastic anemia. Okay? Now, what are hypoproliferative anemias caused by impaired DNA synthesis? Yung mga vitamin deficiency related, those are your megaloblastic anemias. Okay? Now, if you have isolated precursor, erythroid precursor deficiency lang, hindi tatlo, no? Ano siya? That is your pure red cell aplasia. Okay? And then if you have low serum iron, but you have low ferritin, no? If you have low ferritin, you have low iron stores. So that is your iron deficiency anemia. Okay? If you have space occupying lesion, that is your myelophthisic anemia. And if you have your increased ferritin, no? In a patient with decreased serum iron, then that is your anemia of chronic inflammation. In anemia of chronic inflammation kasi, hindi mo ma-utilize yung iron, no? Kaya nananatili siya into storage form. Kaya mataas ang ferritin. Okay? Now, for your bleeding disorders naman, SLE. Anong meron sa SLE? Remember that it can cause immune thrombocytopenic purpura. Therefore, that is a disorder of platelet number. Okay? Now, if you have vitamin C deficiency, remember that your vitamin C is important in maintenance of your collagen, di ba? And in turn, your vessel wall integrity. Therefore, if you have scurvy, then you can have bleeding, and that is because of what? Vessel fragility, no, vessel wall fragility. So the bleeding parameters are expected to be normal. Now, if you have Glanzmann thrombasthenia, that is a defect in your platelet function, but in specifically platelet aggregation kasi yung Bernard-Solier, yung platelet adhesion. Okay? Now, for vitamin K deficiency, remember that you have vitamin K dependent coagulation factors. Therefore, pag vitamin K deficient ka, anong bleeding disorder mo? Coagulation, no? And then if you have acute promyelocytic leukemia, remember that yung mga APML nagdi-DIC sila, so basically coagulation pa rin ang patak, no? And then if you have your von Willebrand disease, now this is also a disorder of coagulation, but remember that your von Willebrand disease can also present with prolonged bleeding time dahil yung GP1B9 ay involved din. Yung factor 8, no? Okay, now let's go to pulmonary pathology. So if you have atelectasis, you have collapsed lung. Therefore, your secretions will not be drained, and that can cause infections, no? Aside from respiratory compromise. Now for your ARDS naman, which is very important, ang nangyayari kasi sa ARDS, you have an insult and it injures your lung vasculature endothelium. No, and when you injure that, it can cause inflammation. That of course will also damage, no, the lung tissue. Kaya ka nagkakaroon ng acute lung injury, and it presents as non-cardiogenic pulmonary edema. Now, between your obstructive and your restrictive lung diseases, yung obstructive lung diseases natin, hindi makalabas yung hangin. Kaya you have increased lung volumes. But for your restrictive lung diseases, you have limited lung expansion. That's why you have decreased lung volumes. And dito pumapasok yung mga fibrosing diseases, including your pneumoconiosis, etc. Okay? For your pulmonary hypertension naman, remember, no, your pulmonary vasculature, once they're overloaded, they can remodel, and that can cause pulmonary hypertension. And if you have an intrinsic lung disease, that can also affect, no, your pulmonary vessels, then it can also cause pulmonary hypertension. Of course, pneumonia, you're so familiar with this. Just remember that you have different patterns of pneumonia na nakikita nyo across organisms. Now, for pleural effusion, of course, it's fluid in the pleural cavity. And whenever you encounter a pleural effusion, no, kung non-inflammatory yan, no, it's a transudate, usually heart failure yan, no? And when you have inflammatory effusions, the two most important causes that you have to consider are infections and especially if hemorrhagic, malignancy. Okay? Now, for your area in your pleural cavity, if that becomes so severe, it can compress your mediastinal structures, and that can cause your tension, pneumothorax. Now, in terms of pulmonary tumors, well, lung cancer lang naman yung super kailangan yung tandaan. Just remember that your adeno and your squamous, these are non-small cell carcinomas, and they're different from your small cell because they're amenable to surgical resection at early stages. While your small cell, if you have a lung cancer, you don't want to have small cell because it's very aggressive. It's not amenable to surgical resection even in its early stages. No, it's very deadly. Okay. Now, and for your malignant mesothelioma naman, hindi na ako nag-bother i-discuss yung morphology because it can mimic a lot of things. But just remember that it's associated with your asbestos exposure. So you have to elicit that in your history. And also, your pleural, they present with massive pleural effusion. As in, pagka-drain mo after 2 liters ulit, ganon, no? Ganon. Okay? Now, for your non-aplastic head and neck diseases naman, for your herpes, they're common. Just remember that they can be triggered by UV light, no, extremes in temperature, and then magpa-present sila ng painful vesicles, no, painful perioral vesicles. For your nasal polyp, these occur in patients with chronic history of rhinitis. They present with nasal congestion because the polyp obstructs your nasal cavity. No, and this is an inflammatory lesion, so you don't see anything funny aside from your inflammation. For your tonsillitis, just remember na kung tonsillitis lang siya na benign, it should be bilaterally enlarged, no? Kasi kapag unilaterally enlarged yan, rule out tumors. Okay? And then bronchial cleft cyst, we already discussed that in the corrections. It usually presents as a lateral neck mass along your sternocleidomastoid, and it's a lymphoepithelial cyst, meaning yung wall niya ay lymphoid tissue. Okay? And it's a true epithelial cyst, so may lining siya. Now, for your thyroglossal naman, imbis na lymphoid, thyroid tissue ang nandun, and it usually presents here, no, anterior neck mass that moves with deglutition and usually close to your hyoid. Okay. Now, the nasopharyngeal angiofibroma, it has angio in it. So, ibig sabihin may blood vessels yan. So, it can present with epistaxis. Okay. Your Schneiderian papilloma naman, it looks like a nasal polyp grossly, but then you see your mucosal hyperplasia. Okay. And then for your paraganglioma naman, just remember, parang ito din yung morphology ng pheochromocytoma, no? Yung cell-ballen with chief cells and then surrounded by sustentacular cells. Now for your salivary gland tumors, the most common benign tumor is your pleomorphic adenoma, no? Followed by your Wharton tumor. Your Wharton tumor is particularly associated with your smoking, and it usually arises in the parotid gland. Now for your head and neck malignancies, madali lang yan kasi lahat sila squamous, no? Madaming squamous, okay? But ang tatandaan nyo, for oral cavity, usually pangit ang prognosis nila and iba yung kanilang risk factors rather than the oropharyngeal because the compared to the oropharyngeal because your oropharyngeal are associated with your HPVs and they have better prognosis. Now, for your nasopharynx, ganun din, but you have to know if it's keratinizing or non-keratinizing because it impacts your treatment. No? Now for your and it's also associated with your Epstein-Barr virus. For your larynx, of course, squamous cell then, usually in elderly males and presenting with your hoarseness and your dysphonia. No? And then you have your malignant salivary gland tumors. The most evil of them is your adenoid cystic carcinoma because it's aggressive and can invade your nerves. And it also usually arises in minor salivary gland sites, meaning kalat-kalat siya sa oral cavity, no? And then for your GIT diseases, you have your achalasia. This is practically ang mnemonic ko dyan, esophageal Hirschsprung. So basically, if you have, para kang nagkakaroon ng dysmotility, no, ng achalasia because nawawala yung iyong mga ganglion cells in your muscularis layer of your esophagus. Now, Barrett esophagus and GERD is something that you know very well, or something that you know very, very well. So if you have chronic acid exposure, that can cause intestinal metaplasia of the epithelium, and that is the precursor for your esophageal adenocarcinoma. If you have portal hypertension, then your portocaval anastomosis will open, no, and in your esophagus, you will have your esophageal varices, and that's an important cause of mortality in your acute liver failure patients, no, pag meron silang variceal bleeding. Now, for your gastritis, it's most commonly caused by your H. pylori, no? But you also have a lot of causes. Just remember that in gastritis, especially if you have atrophy already, that is a precursor for your gastric cancer, okay? Now, yung peptic ulcer disease naman, the main problem is you have a lot of acids. And you know that in your gastritis pathogenesis, di ba? Yung acid, it's an offending factor, no? That can destroy your that can destroy your stomach. Ngayon, meron kasi tayong benign ulcer and your malignant ulcer. So for your peptic ulcer disease, dapat malinis ang itsura niya. Smooth ang border, walang nakaangat, sharply punched out defect, no? But if you have your heat up borders, then maybe we're dealing with a gastric CA already. Okay? And then for your inflammatory bowel disease, of course, your Crohn's and your ulcerative colitis. Remember yung Crohn's nyo, skip lesions, transmural inflammation, no? May non-cacheating granulomas and maraming fibrosis. Okay? While your ulcerative, yun yung opposite niya. You don't have skip lesions, usually continuous, and it just involves your mucosa until sa submucosa. So there's a table there, no? There's a table there naman comparing your Crohn's and your ulcerative colitis. So make sure you focus on that kasi tinatanong talaga yan, no? Now, yung sigmoid diverticulitis, it can present as a left-sided appendicitis kasi yung diverticula na yon pwede yung magkaroon ng retained digesta, no? Pwede magkaroon ng retained food doon, and then pwede yung mag-rupture, no? And then pwede ka magkaroon ng inflammation. Okay? Now, anus hemorrhoids, same way as your esophageal varices, no? Kaso nga lang nasa anus. And then your acute appendicitis, alam nyo na yan, no? The criteria is neutrophils in your muscularis mucosa. Okay? And in terms of your GIT neoplasms, again, for esophagus, you have your squamous and your adeno. Your squamous usually in middle third. And the risk factors parallel that of your head and neck cancers, okay? Na oral cavity. Okay? And then for adenocarcinoma, of course, it's GERD and it arises in the distal third. For your stomach, your carcinoma, of course, you have to elicit the history of H. pylori or autoimmune gastritis or any atrophic gastritis for that matter, no? Now, for your lymphoma, usually it's also caused by your H. pylori because that is the trigger for the proliferation of your lymphoma cells. Okay, you can also have a mesenchymal tumor, your gastrointestinal tumor, and usually it presents as a big mass, no, that can cause extrinsic intestinal obstruction kasi palabas yung growth niya. Okay. Now, for your colon, your adenomas, now these are precursors of your colon cancers, no? Just remember na kapag malaki yung adenomatous polyp mo, malaki yung chance na malignant siya. And also, if villous ang architecture, if you have high-grade dysplasia, or if you have your sessile serrated lesions, because these are definitely associated with malignancies. Okay? So, for your carcinoma, it's an adenocarcinoma usually naman in your colon. So tumor marker is your CEA. Clinically, it can present if nasa right side, iron deficiency anemia because of bleeding, or change in bowel habits kapag nasa left side. Okay, for your appendix, most common is your carcinoid, benign. And for your appendiceal mucinous neoplasms, the important thing there is that is a differential if you have mucinous ascites. Okay. Now, for your hepatitis, there are a lot, no? Your hepatitis, kahit viral yan, autoimmune or drug-induced, halos pare-pareho ang morphology niyan. Different lang ang causes, but history, no? Yung magdidikta ng differences nila. So, of course, you have to have hepatitis B or C infection in your viral. You have to have history of autoimmune diseases in your autoimmune. And you have to have a history of compatible drug intake in your drug-induced hepatitis. Pero halos pare-pareho lang sila ng clinical presentation. Now, yung fatty liver nyo, it can be caused by your alcohol or metabolic syndrome, no? And they go through 3 stages. Your steatosis. Now, this can cause inflammation of the liver and therefore a risk factor to develop liver cancer. Your inherited liver diseases also, for your hemochromatosis, it's iron excess. For your Wilson, it's copper excess. And for your alpha-1 antitrypsin deficiency, it's an accumulation of a dysfunctional, no, and abnormal alpha-1 antitrypsin. So those, no, can also cause liver inflammation and liver damage and are also risk factors for liver CA. Okay. Now, for your cholestatic, if you have a history of biliary obstruction and your patient presents with right upper quadrant pain, fever, and jaundice, entertain your ascending cholangitis. Now, if you have a neonate, no, with obstructive jaundice and hepatomegaly, think your extrahepatic biliary atresia. We also have your autoimmune cholangiopathies, no, your primary biliary cholangitis, which usually occurs in females, no, and your primary sclerosing cholangitis, which usually occurs in males. And they have differences, no, diniscuss ko na yan sa handout. Now, for your nodules, your focal nodular hyperplasia, it's a tumor-like lesion, but it's not neoplastic. Okay? And then yung gallbladder diseases nyo naman, you have your gallstones. Okay? So remember that your gallstones are risk factors for gallbladder CA. Yeah. So yung cholecystitis, most commonly, it's caused by stones. So alam nyo na ang presentation ng cholecystitis naman, no? Usually right upper quadrant pain. Okay? Now, for your liver tumors, no, you have your hepatocellular adenoma. It's associated with your oral contraceptive pills, anabolic steroid use, obesity and metabolic syndrome, and some of them, especially when they have beta-catenin mutations, can be precursors to Hep CA, no? Then your Hep CA, tatandaan nyo, ang prominent risk factor niya ay chronic liver disease with cirrhosis. And the marker is your alpha-fetoprotein. For your bile ducts naman, you can have involvement of your intrahepatic and extrahepatic bile ducts. So, intrahepatic bile ducts usually presents as a liver mass, but if hepatic bile, these cancers also are associated with chronic inflammation, no, of the biliary tract. And then for your gallbladder CA, risk factors are gallstone, include your gallstones. And the most common histology is your adenocarcinoma. Now, because medyo tago yung gallbladder, no? Tapos nakadikit pa siya sa liver, usually madali siyang kumalat, kaya na-diagnose siya late na. Now, for your pancreatic pathology, it's just your pancreatitis and your pancreatic carcinoma. So basically, it is governed, no, yung pancreatitis by your basic principles of your inflammation and repair. Okay, so yun lang din yung makikita yung morphology in your acute pancreatitis. Usually, those edema, acute inflammation, mga ganon. And then for your chronic pancreatitis, usually fibrosis, atrophy, no, of your parenchyma. And that will translate clinically, of course, for chronic pancreatitis with pancreatic insufficiency, no? While for your acute pancreatitis, it's yung classic na abdominal pain plus your systemic inflammatory response syndrome. Now, pancreatic carcinoma, one of the most lethal because ang ano niya ma-detect, no? Late siya na-detect. Most important risk factor is smoking. If it occurs in the head, which is the most common site, you can present with obstructive jaundice. But malas mo pag body and tail kasi di mo siya ma-detect until advanced na. Tumor marker is CA19-9. Now, for your nephritic and nephrotic syndrome, for your renal, alam mo naman kung anong presentation ng nephritis. Ng nephritic, usually hematuria, di ba, oliguria, hypertension, azotemia. But for nephrotic, it's the proteinuria. So these are the diseases. Okay? And then for your tubular diseases, your acute tubular injury can be caused by a lot of things. Ischemia, toxins, but basically you slap off your epithelial cells, they organize into cast, and they occlude your tubules. And that's the reason why wala kang urine output kapag meron kang acute tubular injury or bawas siya. Okay? Now, for your pyelonephritis, these are UTIs, no? Upper UTIs. So, governed pa rin siya ng inflammation and repair. So, for acute pyelonephritis, usually infections, no? So, you have your pyuria, fever, CVA tenderness. But for chronic pyelonephritis, usually renal insufficiency ang meron sila. For your cystic diseases of the kidney, remember lang na yung dominant siya yung may intracranial berry aneurysms and yung mitral valve prolapse. And then super maraming cyst yung kidney niya. While for your autosomal recessive ARPKD, usually in children, they suffer from renal failure in infancy. And if they survived infancy, they will have congenital hepatic fibrosis. And then for your renal cell CA, ang kailangan nyo lang tandaan dito, you have hematuria, flank pain, or mass, no? Yun yung and mass, yun yung triad niya. So this is one differential for your patients with painless hematuria. Okay? You have different histologies, and for me, importante lang sila because they're associated with certain genetic syndromes na pwedeng itanong sa inyo. Otherwise, kailangan nyo lang malaman, no, paano mo nyo madadiagnose yung renal cell CA. So usually you have a renal mass, no, a flank mass, no, flank pain, and then hematuria. And then remember that the most important risk factor is your smoking. Remember also that this is a cancer that can hematogenously disseminate because it's a very, very, very vascular organ, and it has direct access to your caval circulation. Okay? Now, for urinary bladder, masyado ng toxic yung morphology niyan. Basta basically, your bladder cancer can start as non-invasive lesions and then eventually will become invasive. And the clinical presentation is painless hematuria. So, dalawa silang differentials nyo for painless hematuria. And smoking din ang kanyang, anong tawag doon? Risk factor. So, additional note, your squamous cell carcinoma of the bladder, schistosoma, hematobium. Now, for your penis, you also have squamous cell carcinomas that can either be HPV or non-HPV related, and they have different risk factors. Siyempre, for HPV related, you have your high-risk HPV infection. But for your non-HPV related, you have your other inflammatory disorders. For example, if you have posthitis, balanopostitis, mga ganon. No? And then for your cryptorchidism, very important. So, undescended testis, the main significance of this is it increases your risk for testicular cancer. Now, going to germ cell tumors, ang kailangan yung tandaan dito, your seminoma is the most favorable, no? Your seminoma is the most chemosensitive, no? It's a chemosensitive, and your radiosensitive tumor. Now, the rest, your embryonal, your choriocarcinoma lalo, lahat yan ay pangit ang prognosis. For your yolk sac tumor, if it occurs in children in the prepubertal type, no, that has excellent prognosis. And for your teratoma, if it occurs at prepubertal age, no, also has a good prognosis. Okay? For your sex cord stromal tumors, just remember na yung Leydig can produce endocrine effects. And therefore, in your history, kailangan yung hanapin yung history ng endocrine manifestations. For example, gynecomastia, no? Baka Leydig yan. But Sertoli cell tumors are typically hormonally silent. Okay. Now, for prostate, your nodular prostatic hyperplasia usually arises in your transitional zone or inner periurethral zone. So, it compresses the urethra, kaya obstructive ang usual symptoms niya. But for your prostatic adenocarcinoma, it arises in the peripheral zone sa likod, kaya nakakapamo yan by DRE. Okay? And the tumor marker is your PSA. It's also noted to noteworthy, no, na nagme-metastasize sa may lumbar spine. Okay? So in an elderly patient with lumbar mets, rule out prostate CA. Now, Bartholinsis, ang kailangan nyo lang tandaan dyan, pag more than 40, rule out malignancy, kaya biopsy. The vulvar squamous CA is the same, no, like your penis, and the paget is the same as that of the breast, but it's not associated with malignancy, unlike that of the breast. For your vagina, your sarcoma botryoides, usually pediatric patient with grape-like mass protruding sa may introitus niya, that can cause local extension to the urinary tract, and that can cause obstructive uropathy. And then for your cervix, endocervical polyp can cause your postcoital bleeding, no? And of course, you have your intraepithelial neoplasia, which are precursors of your cervical cancer. Okay? For your endometriosis naman, usually the presentation is infertility and cyclic pelvic pain because nagbe-bleed yung mga endometrial implants mo. Why infertility? Because if it involves your fallopian tubes, for example, you know that bleeding will lead to fibrosis. Basically, pag nag-fibrose yung fallopian tube mo, magiging infertile ka. Okay? So that's the reason kaya ka nagkakaroon ng infertility in your endometriosis. And for your adenomyosis, these ectopic endometrial glands are within the deep myometrium. So ibang clinical presentation nila, no? Heavy menses yan usually. Now, for endometrial disorders, remember that they will present with abnormal uterine bleeding. So depende na lang sa biopsy kung siya ay endometrial polyp, hyperplasia, or carcinoma. Now, we have two types of your endometrial carcinoma. The endometrioid, which is better, and the serous and the carcinosarcoma are the worst ones. Okay? Now, for your leiomyoma, common yan. I'm sure marami nang nakakita sa inyo, no? These are just composed of your benign smooth muscle cells. But if you have leiosarcoma, hindi sila well circumscribed. They look necrotic and hemorrhagic, and they're very bulky and infiltrative. So malignant yon. Okay. Now, for ovarian tumors, the common clinical presentation is, of course, a pelvo-abdominal mass. Just remember that your serous is most of the time bilateral. Your mucinous are most of the time unilateral, and they can reach very, very large sizes and are associated with your mucinous ascites. So in a female na may mucinous ascites, you check for your ovary and your appendix. So you also have endometrioid and clear cell, and these are associated with your endometriosis. Okay? And the reason for that is that may mutations yung endometriotic implants. Kaya may associated sa kanya na mutation na CAs. Okay? Now, for your germ cell tumors, ito lalakdawan ko na to, na-discuss na natin to, no? But for your ovarian teratomas, it's the presence of the immature component that dictates prognosis. So pag immature teratoma siya, malignant siya. Okay? And then you have your sex-cord stromal tumors, your granulosa, you have your fibromaticoma. Now, some of them can cause hyperestrogenism. So aside from that, you have to look for symptoms of estrogen excess. And now we have your gestational trophoblastic diseases. So H-moles. H-moles are important differential diagnosis when you have a patient with bleeding in the first half of pregnancy together with your abortion and your ectopic pregnancy. Okay? So ano yun? Abortion, ectopic pregnancy, and H-mole. So yung H-mole, may partial and complete yan. Meron na akong diniscuss ko na yan sa handout. Okay? And then for your invasive mole, they can go to your uterine vessels. They can go to your myometrium. And your choriocarcinoma is a gestational trophoblastic neoplasia. So how will you distinguish them from moles? They don't have villi. Okay? They're just malignant cyto and syncytial trophoblasts. Okay? Yun lang yan. Now, for your breast naman, you have your fibrocystic change. Lagi nyo nakikita to. No? Common to na lesion. Okay? So, pag fibrocystic change, benign yon. Okay? So, you just have your fibrosis, you have increase in your acini, your adenosis, and some of them dilate, kaya ka nagkakaroon ng cystic change. For your papillary neoplasms, your intraductal papilloma, pag na-traumatize yon, no, they're usually in the large duct system. When they get traumatized, you will have bloody nipple discharge. Now, they are benign. Now, your breast cancers, they develop from your carcinoma in situ, and then they eventually become invasive carcinoma. Okay? And then you have different morphology. Okay? Now, for your fibroepithelial tumors naman, you have your fibroadenoma and your phyllodes. Remember, your fibroadenoma, usually reproductive age group, no, medyo bata-bata yung patient, maliit yung mass, no? And if you look at the biopsy, you see a balanced proliferation of your epithelial and your stromal elements. While for your phyllodes tumors, they're usually found in your elderly patients. Usually malalaki yung breast masses nila, and minsan nag-ulcerate pa, no? So these are characterized by stromal overgrowth, no? Rather than your epithelial, mas nagpo-proliferate yung stromal. Now, let's go to endocrine. If you present with gigantism and your acromegaly, ano kaya dyan? It's your growth hormone, so your somatotroph adenoma. Now, if you have a posterior pituitary syndrome, that you have your increased ADH, no? And when you have your increased antidiuretic hormone, you don't diurese, no? And therefore, meron kang water retention, kaya bumababa yung serum osmolality mo. So that is your SIAD, okay? That is your syndrome of inappropriate ADH secretion. Now, if you have hyperglycemia, no, and you have adrenal gland hyperplasia, that is what? That is your corticotroph adenoma. Bakit? Because it produces ACTH. Kaya lumalaki ang adrenal gland mo. Okay? Now, if you have low ADH and you have low urine osmolality, well, kasi meron kang low ADH. So, ibig sabihin, magdadiurese ka. Kaya magkakaroon ka ng large volume of dilute urine. Okay? So that is your central DI because the defect in central DI is decrease in your ADH. But what if you have increased ADH naman? Pero, or normal ADH, but you have still that decreased urine osmolality typical of DI. Maybe you're dealing with a nephrogenic DI. Maybe your kidneys are not sensitive to your antidiuretic. What adenoma are we dealing with? It's your prolactin cell adenoma, prolactinoma. Now, what is the single most important thyroid function test? It's your thyroid stimulating hormone because that can differentiate your primary and your secondary hyper and or hypothyroidism. Now, what antibodies are associated with your Graves' disease? It's your thyroid stimulating immunoglobulins or antibodies. Okay? So it acts like TSH kaya nagpo-proliferate yung iyong thyroid. Biochemical profile of long-standing Hashimoto thyroiditis patients. Or recall, no? Meron tayong chronic inflammatory disorder of the thyroid gland. So ibig sabihin, ano kaya ang kanyang profile? Siyempre, hypothyroidism, no? And this, because it destroys the thyroid gland, this is a primary hypothyroidism, no? And therefore, the body is instructed, no, to produce increased TSH para i-push si thyroid na mag-produce sana ng thyroid hormone. Pero of course, sira na nga si thyroid, so walay. Okay? Now, underlying cause of goiter is your inadequate thyroid hormone synthesis. Okay? Kaya lumalaki ang ating thyroid, it's because to compensate, no? To compensate for that decreased thyroid synthesis. Kasi ang nangyari in your goiters, if you have deficient thyroid synthesis, you will produce TSH, no? And that causes growth of your thyroid gland. Orphan anenuclei, of course, papillary thyroid cancer. And what's the cancer associated with your amyloid and your high calcitonin? That's also a member, a component of your multiple endocrine neoplasia syndrome, like the MEN2, is your medullary thyroid cancer. Okay? So if you have a follicular tumor, no, ng thyroid with capsular and vascular invasion, that is your follicular carcinoma. Ano to? PTH secretion stimulated by chronic hypocalcemia. Ano yon? Primary or secondary? That is secondary hyperparathyroidism. Kasi pag primary, the parathyroid is the problem. Okay? The parathyroid autonomously produces your PTH. Now, what's the first differential diagnosis for a malignant spindle cell lesion in your thyroid? It's your anaplastic thyroid CA. Okay? Yung autonomous PTH secretion, diniscuss ko na, it's your primary hyperparathyroidism. Okay? And reliable criterion for diagnosing parathyroid carcinoma, METs. Okay? Kailangan METs. Primary hypothyroidism with multiple gland enlargement. Okay, remember, in your parathyroid disorders, di ba meron tayong 4, no? So pag single gland lang yon, that's adenoma. But if it's multiglandular, then that is parathyroid hyperplasia. Okay? Now for your DM, no? If you have autoimmune destruction of your islet cells, ano yon? Type 1 or type 2? That's your type 1. Okay? What's the fundamental abnormality in your diabetes mellitus? Of course, their blood sugar is elevated. No? Insulin resistance, anong type siya? Type 1 or type 2? It's your type 2. Okay? Now, what's the consequence of severe insulin depletion aside from your hyperglycemia? It's your ketoacidosis. Remember the pathogenesis of your DKA. If you have super babang insulin levels, no, it will promote your ketogenesis, no? And that can cause your ketoacidosis. Now, characteristic of diabetic macrovascular disease, remember that your diabetes is one of the coronary risk factors and therefore can accelerate atherosclerosis, no? Now, what's the organ that affected in your diabetic microvascular disease? Ano yun? Kidney. Aside from that, ano pa? Retina at saka nerves, okay? If you have virilizing adrenal tumors in children, anong isususpect mo? Adenoma or carcinoma? That is carcinoma. Okay? Now, if you have hypokalemic hypertension, that is your Con syndrome. Diba? That is your primary hyperaldosteronism. If you have salt wasting, no? And you have cardiovascular collapse, okay? Ano yun? That is your deficiency in your mineralocorticoid and your glucocorticoid. So what's that? It's your congenital adrenal hyperplasia because of the deficiency in your 21-hydroxylase. Remember, you cut your adrenal steroidogenesis pathway, and all of those are directed towards adrenal androgens. Okay? Hyperglycemia, it's your Cushing syndrome, of course. And then for your sympathetic symptoms, you know that it's something that should be related to the adrenal medulla, and therefore your pheochromocytoma. Test that differentiates primary and chronic secondary adrenal insufficiency. It's your ACTH stimulation test. Okay. So, in your adrenal insufficiency, if it's primary, the adrenal is the problem, diba? So, if you stimulate it with ACTH, walang epekto yun. Kasi nga, sira na nga yung adrenal. But for your secondary adrenal insufficiency, ang problema kasi dyan, decrease ACTH output. So, you give that output and the adrenal will be fine. Okay? Now, men, okay, tinatanong to. So, pag triple P, ano yon? Your men 1. Okay? But if you have your men 1 plus nets in your other sites, that is your men 4 or your men 1-like syndrome. Now, if you have medullary thyroid carcinoma, di alam mo na, mento na yun, no? And you have neuromas, that's your mucosal neuroma syndrome, that's your men 2B. Okay? And if you have, instead of your neuromas, you have your parathyroid, no? Together with your medullary thyroid cancer and your pheo, that is your men 2A. Okay? Now, in terms of derm path, so A is, ano yan? A is your psoriasis. As you can see, your test tubes in a rack appearance. Your B is your melanoma. As you can see, they produce pigment, no? And then your C is your basal cell carcinoma, so you see and your stromal retraction. And yung D is yung squamous cell carcinoma mo, you see your keratin pearls. Actinic keratosis as your pre-invasive lesion, that is for your squamous cell carcinomas. Okay? Your Munro microabscesses and spongiform pustules of Kogoy, those are mentioned in your psoriasis. No? Sun exposure as your risk factor, your skin cancers. Okay? Your skin cancer. So wear your sunscreens. Okay? What is an autoimmune dermatosis among here? Of course, the rest are tumors, then we're left with your psoriasis. Okay? It's the locally aggressive one but has negligible or low metastatic potential, which is a topic kanina. It's your basal cell cancer. Now, what is S100 positive among all of these? The one that are derived from neural crest cells, which are your melanomas. Okay? Now, for your MSS, if you have an adolescent with a knee mass, no, and you look at the biopsy, you see malignant cells that form bone or osteoid. Ano yun? Osteosarcoma. Okay, that's osteosarcoma. If you have a 28-year-old male, no, na may RMAS, and then meron siyang cartilage cap, that is your osteochondroma. Okay? If you have a pediatric patient, no, with systemic symptoms and a mass, aside from your osteosarcoma, ano pang isipin mo? Ewing sarcoma. So, sa kanya, ang morphology niya is small round blue cells, so we lean towards Ewing sarcoma. Okay? Now, this one is an elderly scapular mass, so axial skeleton, and you look at this, you look at the biopsy and you see malignant cells in a cartilaginous matrix. So that is your chondrosarcoma. Okay? Now, 40-year-old male with a lot of multinucleated giant cells, no, 40-year-old female knee mass with a lot of multinucleated giant cells, that's of course your giant cell tumor. Okay? Now, this one is a femoral femoral mass naman. You have woven bone, curvilinear trabecular woven bone without osteoblastic rimming. So that is your fibrous dysplasia. Kasi yung osteoid, osteoma, may osteoblastic rimming. Fibrous dysplasia, walang osteoblastic rimming. Okay. Differentiate, these are 3 to these. Okay. Degenerative, that's your osteoarthritis. So it relates to wear and tear. And therefore, the most abused joints are the ones at risk of developing osteoarthritis. Okay. Now, for your calcium pyrophosphate crystals, that is for your gout or pseudo-gout. That is for your pseudo-gout. Now, intense chronic inflammation, Rheumatoid or osteo, that will occur in your rheumatoid arthritis because that is an autoimmune disease. Okay? Systemic symptoms doon sa autoimmune disease. So that's rheumatoid arthritis. Bony ankylosis or fusion, it's because of the fibrosis after the chronic inflammation. So what's that? That is rheumatoid arthritis again. Okay? Mostly affects weight-bearing joints. So that is in keeping with the degenerative pathology, and therefore that is osteoarthritis. Exquisite pain during acute attacks, that is what? Your gout. Okay? Your gout. Now for monosodium urate crystals, that is gout, of course, urate, no? And then if you have your antibodies, of course, you pick the one that's autoimmune, no? Your anti-citrullinated peptide antibodies is for your rheumatoid arthritis. Now let's go to some tumors. If you have a liver mass with an exposure sa polyvinyl chloride, that is your angiosarcoma, no? Now this one, a uterine mass. Ano bang nakikita mong tissue sa uterus? Smooth muscle. So your diagnosis is leiomyosarcoma. Now, if you have a pediatric patient with the right ventricle mass, no, and you have spider cells in morphology, that's in your cardiac tumors. That's your cardiac rhabdomyoma. Okay? Because those are spiders, no, cytoplasmic processes yon, and then yung empty spaces are the glycogen na sinustore naman talaga ng skeletal muscle cells. For retroperitoneal cells, mixture of mature fat cells with few atypical cells. Retroperitoneal, so usually well-differentiated liposarcoma, no? And then, diniscuss na rin natin to yung 5-year-old na may vaginal mass na grape-like, no? That is your embryonal rhabdomyosarcoma. Now, if you have a neurofibromatosis patient and a sarcoma occurs in that patient, you have to consider your malignant peripheral nerve sheath tumor. Okay? Now, this one is an elderly male with a knee mass and non-Paget disease of bone patient. So that is your secondary sarcoma, no? Which is a complication of your Paget disease of bone, can be osteo or fibrosarcoma. Now, if you have cardiomyopathy, mental retardation, and progressive muscle weakness, that is your Duchenne muscular dystrophy. Remember, your dystrophy is present in your CNS. It's also present in your heart. Kaya ganyan yung triad niya. Okay? Now, if you have dermatologic manifestations in an inflammatory myopathy, such as your Gottron papules and your heliotrope rash, ano yun? That is your dermatomyositis. Now, diplopia as an initial presentation, remember that your neuromuscular disorders, no, yung myasthenia gravis nyo and your limbs, your myasthenia gravis affects your EOM. So that is the answer. Okay? Now, if you have a post-varicella patient, then nagkaroon siya ng symmetric ascending paralysis, no? And can involve, no, your respiratory muscles. So pwede silang mahook sa ventilator. That's your Guillain-Barré syndrome. Okay. Now, if you have small cell lung cancer and you have weakness in your extremities, then maybe we're looking at your neuromuscular disease, your Lambert-Eaton myasthenic syndrome. And if you have lack of sensation on both feet and hands with your non-healing foot ulcers, maybe you have diabetes. So that is your diabetic neuropathy yan. Okay, neuropathy yan. Sorry for the error. Okay. Now for your peripheral nerve sheath tumors, okay, if you have CD34 and S100 in combination, no, that is your neurofibroma. So remember, they have Schwann cells kasi and they have CD34 positive cells. Kaya sila pareho nagpa-positive. Your cafe au lait spot, saan mo siya nakikita? Your neurofibromatosis type 1. Ang ependymoma saan? Sa 2. Okay? Yung Anthony A, B na pattern of your peripheral nerve sheath tumor with your Verocay bodies in your S100, that is your schwannoma or neurofibroma. Schwannoma. Okay, that's your schwannoma. Now, your Lisch nodule, saan siya nakikita? In your NF1. Okay? Meningioma is in your NF2. Okay? And your pheochromocytomas are in your NF1. Okay? Now, neuro last. Okay? 4 minutes left. Herniation syndrome with lower extremity weakness and sensory loss. Anong meron? It's your subvalcine herniation. Because remember, if it herniates dun sa may falx, ang pwede nyo makompress ay your anterior cerebral artery, and that supplies your lower extremities. Now, if you have autosomal dominant PKD patient, no, may polycystic kidney ka, remember binanggit ko na ano yung kailangan yung tandaan in your ADPKD? It's your perianeurysms, no? So, kung may perianeurysms ka, anong klaseng hemorrhage? That is your subarachnoid hemorrhage. Okay? Now, herniation syndrome with your third nerve palsy, saan ba siya dumadaan? Malapit sa may tentorium, kaya it's transtentorial. Now, if you have a terion fracture with rapid neurologic deterioration with lucid intervals, then your middle meningeal artery might have been compromised and nagkaroon ka ng epidural hematoma. Okay? Now, if you have a seizure disorder, no, with a bag of worms lesion on your cranial CT, now those bag of worms may represent your abnormal vessels, and that is your AV malformation. Okay? Now, for the types of meningitis, okay? Alin yung una? You have lymphocytic cells, no? You have lymphocytic cells in your CSF. You have markedly elevated protein and a positive culture in your LJ medium, which is for your TB. So, siya ay tuberculous meningitis. Okay? Now, if you have a neutrophilic CSF, no? Neutrophilic ang nakikita mong cells, and you have a markedly decreased sugar with a positive culture, so that is your acute pyogenic meningitis. Now, if you have a lymphocytic, no, with normal glucose, no, and the culture is negative, then maybe we are talking about an aseptic meningitis. And since it's lymphocytic, maybe it's because of a virus. Now, for some neurodegenerative disorders, so diniscuss ko namang maigi yan in your neuropath, no? Yung generalities niya, para madali nyo siyang aralin. So, ito, if this clinically presents with dementia, you have your neurofibrillary tangles and your neuritic plaques. Ano siya? That's your Alzheimer disease. Now, if you have extrapyramidal symptoms, no? And you have pallor of your substantia nigra and Lewy bodies, no? Composed of your alpha-synuclein, that is your Parkinson disease. Now, if you have atrophy of your motor centers, na? So motor, alin yun? That's your amyotrophic lateral sclerosis. Last, a kid with a cerebellar mass with mural nodule and you see your Rosenthal fibers. So saan nyo siya nakikita? Kid ha, may Rosenthal fibers. Okay, so that is your pilocytic astro. But what if you have a kid with a cerebellar mass also, but it's small round blue cells? That is your medulloblastoma. Okay, now if you have a 34-year-old male, an ill-defined parietal mass, may atypia mitosis necrosis microvascular proliferation, and an IDH wild-type glioma. That is your glioblastoma. So, glioblastoma, super bad prognosis. Kawawa naman yung patient. Now, if you have an NF2 patient, alam nyo na kung ano mga nandun. No? Meningioma, ependymoma, di ba? Sa NF2. Okay? But this one has a spinal mass with perivascular pseudorosette. So, anong buzzword yon? That is your ependymoma. Okay? Now, next is if you have a well-defined parietal mass with a fried egg appearance, no, that is characteristic of your oligodendroglioma. And if you have a dural-based mass, it's an extra-axial mass. It's outside of the neuraxis, outside of the brain and spinal cord. And it's a dural-based mass. Then maybe we're dealing with a meningioma. Okay? Now, last, ophthalmologic emergencies. Ano-ano yon? Your retinal detachment and your CRAO, no? Your central retinal artery occlusion. Now, you know that most cases of conjunctivitis can resolve on its own, but what is something that's scary because it can lead to significant scarring? That is your chlamydia, no? And then, if you have a lymphoma, if you have a melanoma in the liver, saan ka feature of proliferative diabetic retinopathy? No? It's your exudates ba or neovascularization? It's your neovascularization. Okay? So what structure in your retinoblastoma indicates photoreceptor differentiation? So ito yung small round blue cells plus your Flexner, Wintersteiner rosettes, and florets. Okay? And if you have bilateral optic nerve edema, anong meron sa kanya? Increased ICP. Kasi pag isa, baka obstruction lang or baka may compression lang ng nerve. But kung bilateral yan, you think increased ICP. So basically, those are, I think, the important concepts that you have to remember, no? Aside from, of course, the very detailed handout that I gave you. So this is my last slide. Nag-extend ako ng 2 minutes. So thank you very much, students, for bearing with me. I know that it's very, very long, but ganun talaga ang patho. And I need you to understand that. Hindi ko talaga siya mapapaikli however I want to. No, but I can make it better for you na in such a way na maintindihan nyo sana siya. No? Especially kung hindi nyo man siya naintindihan during med school. So thank you again. And I want to leave lang with a note na to, no? You can face this. Yeah, you can face this. So alam ko mahirap kasi nga online pa rin, and then parang ang hirap mag-aral because ang daming distractions, no? But focus on your goal. Focus on your licenses, okay? And once you get your licenses, I just want to say that it's not your brains that's going to get you far, no, in your practice. It's your attitude. So learn to respect your elders, learn to respect your juniors, learn to respect your colleagues, learn to respect your patients, and a lot of patients will flock to you. Your practice will be very fruitful. So importante ang attitude after nyong makuha ang lisensya nyo, because that will make or break everything. Okay? So remember to be kind kasi hindi lang kayo ang may mental health na pinoprotektahan, lahat tayo meron. Okay? So thank you very much and I hope that you have learned something kahit papaano.